Great. So today's session, titled Bridging the Gap in Maternal Health, Engaging Hard-to-Reach Populations for Better Outcomes, is brought to us by Vita Health. Vita Health has been a longtime supporter and partner of MHPA and our health plan members. And I just want to thank the entire Vita team for organizing today's session and sharing their expertise with us. So we have three great presenters with us today, Shameet Luhar, Dr. Debra Jones, and Amy D. Dominicus. Shameet is the co-founder and CEO of Vita Health, an outcome and analytics company transforming access to care for underserved populations. With nearly 2 decades of leadership in payer-focused technology and prior roles at Anthem and CareFirst Blue Cross Blue Shield, Shameet has built innovative models that strengthen member engagement and advance health equity. Dr. Debra Jones, who is the Senior Medical Director at Vita Health, is a maternal fetal medicine specialist with over 30 years of experience. She leads the company's clinical quality and maternal health initiatives, integrating her global perspective and data-driven approach to expand health equity and outcomes through virtual care innovation. And Amy is the Vice President of Clinical Development and Design at Vita Health. She brings over 25 years of hands-on healthcare experience to her leadership in chronic care program design. Her background spans emergency, behavioral, and complex care management, where she has earned recognition for advancing patient engagement and improving care delivery models across Medicaid and Medicare populations. So I want to thank all three of them for joining us today. And with that, I'll go ahead and turn things over to Shameet.
All right, Eric, thank you so much. And I want to wish everyone a happy Wednesday. We appreciate you spending some of your Wednesday afternoon with us on this very important and key topic that we continue to hear as we're having conversations, with leaders such as yourselves, across Medicaid health, and that is the topic of maternity. As we look at each of the 50 states, every single Medicaid agency has set forth an ambitious agenda for maternal health, which is how do we improve infant morbidity and mortality rates? How do we enable our mothers to not only set their path on a healthier pregnancy, but then also to deliver a full-term baby? And once they've delivered that full-term baby, the third item, which is how do they continue to be involved in their healthcare through continued postpartum visits with their provider, not only for them, but then also their child. So we're really excited to speak with you today on, what we have seen as some key themes in the industry and a how a strategy on engaging these populations in the right way can lead to outcomes that reduce NICU stays, improve average gestation to delivery at full term, and also accelerate delivery cost improvement. And so before we jump into the topics, one of the things that we'd like to do is ask a polling question. And you're going to see this on your screen. And the question is as follows. How effective is your organization's current maternal health strategy at engaging your high risk, hard to reach moms and improving those moms' outcomes? So we'll give everyone about a minute or so to complete their poll and respond. Right. And we appreciate everybody's responses here. So we've got about more than half the folks who have responded. And if I were to rank the response here, it looks like it's been minimally effective or moderately effective, is which is okay because that's why we're all here on on this webinar, which is we want to get to a place where our maternal health strategy goes from minimally or moderately effective to very and extremely effective. And so thank you so much for that input. And so why don't we start with some simple framing here about, why we see these challenges in maternal health, right? And this slide breaks down in a very practical way how we're seeing that fragmentation, because when fragmentation is showing up in our for our moms, that's what creates challenges to creating clinical and operational outcomes in a way for you as a health plan leader to deliver on. So, Dr. Jones, I thought we could start with you. What are we seeing in the marketplace in terms of key challenges here?
Thanks, Shameet. I want to echo what Shameet just said in terms of thanking everybody for showing up today. This is High Risk Pregnancy Week, so I'm really excited that we can shine some light on maternal health
Hmm.
and some of our challenges that we still face in terms of improving outcomes. This slide illustrates to us what are the costs of fragmented care, and we think that fragmentation of care at Vida is one of the biggest driving force for poor maternal outcome. 75.7% of pregnant women lack adequate prenatal care. It's not consistent. They might not have access to providers, and that drives high emergency room utilization and poor obstetrical outcome. Premature birth rates are high. NICU stays are high. Costs are high. There's a lot of women with chronic conditions, hypertension, diabetes, obesity, which we didn't put up on there, but obesity. And this really drives preterm birth and poor outcomes for mothers and their babies. Access to providers, another big problem in our rural areas, even in our urban areas, where our patients don't have the ability to see providers because they don't take their insurance. And that, again, increases the risks of preventable pregnancy-related deaths. 73%, almost 74% of all pregnancy-related deaths are preventable if we had better solutions of how to deliver care to our mothers. Cesarean section rates versus vaginal deliveries, again, we all know that increases morbidity and mortality for the moms. And if we can find a way to decrease cesarean section rates, primary cesarean section rates, that should improve outcome, NICU stays, and costs. And of course, the Holy Grail, which we love to talk about here at Vida, is how do we engage people and keep them in good postpartum follow-up. 66% of postpartum depression patients, they go undiagnosed because they're not seen by their OBGYN doctor. Postpartum is the area where we have majority of the postpartum deaths occur in that area. And again, mental health. A lot of women undiagnosed don't receive counseling, and suicide is a primary reason for one of the primary reasons for preventable postpartum deaths.
So I appreciate you providing this overview for us, Dr. Jones. And if I were to summarize, our moms are dealing with they're managing a lot. right? They're managing a
They're
lot
managing.
from the perspective of, a new life that they're going to be bringing into the world. But then there's also external, quote unquote, pressures, if you will, that are making that pregnancy a little bit more difficult than than it should be. And then you add on top of that the healthcare system as it's structured today. And would you say it's just complex? Are we asking our moms to do too much?
I think we're asking our moms to do too much to navigate the complex healthcare system on their own. Unfortunately, physicians, we have, you know, limited time to help our patients navigate very complicated uh, healthcare system, complicated care plans, and we expect them to have, high health intelligence and be able to, really figure out what's going out on and how to advocate for their own health care. And I think anytime that we can intervene and help them with that, that improves outcomes. Support them. I think
Yeah.
support them with it will improve their outcome.
No, I think that's totally right. So, when you step back and you look at these challenges, I think it's fair to say that these are not all isolated issues, right? They're all symptoms of what we're continuing to see in our complex healthcare system, and it's fragmented, right?
It's fragmented, absolutely fragmented.
Yeah.
That's fragmented, siloed, not one part speaking with the other, not connecting
Yeah.
patients with different providers, and it's difficult for them again to navigate
Yeah.
through all of that.
Yeah, and a lot of that difficulty is because, if you're a health plan leader like the ones that are sitting on this webinar, the health plan's primary fiduciary, is to provide health insurance. And so what has happened over the years now is we're seeing health plans are increasingly required to provide a number of other, services, whether it's anything from, food as medicine program to housing services, et cetera. And all of this creates a magnified effect into a complex, fragmented healthcare system that our moms are now having they're having to navigate, right? And so what we then see, it seems like, a a place where our moms are not engaged. Is that fair to say?
Engagement is the most difficult uh, part of the whole
Uh-huh.
pie. To get them not only engaged, but to keep them engaged throughout the pregnancy and beyond.
Right. And
That's the big challenge for providers, for healthcare companies to keep patients engaged throughout the pregnancy and beyond.
Right. And because of that engagement, what we typically see is, as you noted earlier, is we have mothers who are delivering through a higher rate of primary C-section. We're seeing higher utilization as a result. And because of those two NICU stays for moms who are delivering babies that are less than full term, are creating delivery costs that are putting stress, on the system. And ultimately, that's creating opportunities for improved quality and just poor outcomes as we're as we see in the system. And so, Amy, I wanted to bring you into the conversation a little bit. Maybe you could share from your perspective, what you're seeing operationally as it relates to this fragmentation.
Yeah, so I think you've stated a number of different things, but really at the core, there is that operational challenge. Really plans are, from what I can see, ongoing, trying to manage increasingly complex members.
Hmm.
which we've seen more and more of today. And I, anticipate that will continue. But these workflows, because they're fragmented, you have your different team members, maybe different vendors, and all of these people working to support the same member, the same patients. They might be using different systems to document or to call or to capture outcomes. Everybody's doing their part, but we're
Right.
not doing it together, or we're not doing it in a way that can be really shared. And what that does, from what I, can see, it really creates multiple touch points. There's a lot
Mhm.
of inconsistent follow through, from the members' perspective, different groups calling the same members, and a lot of room for members to kind of fall off the path of care, right? That care continuum.
Yeah.
Um, and I think, like, the impact, to put it simply, the outcomes tend to stall. No one provider has, a full connected view of their patient. And I'm sure, Dr. Jones, you've experienced this, and certainly with that comes lower engagement.
Mhm.
And for the member, I feel like that takes place because it's a series of these disconnected nudges, these separated um, outreaches and instances, rather than having a real guided journey throughout their whole process, not only in health, but certainly in maternal care specifically. And then ultimately, we see these costs rise
Mhm.
because members, with every handoff, there's the potential, again, to not only drop off, but introduce friction. And that friction leads to avoidable utilization and
Mhm.
rework over and over and over again. So
Mhm.
I feel like this slide shows, I refer to it more of a maze. We have this maze that we've unintentionally created, and
Yeah.
members are forced to try to navigate it. Care teams
Mhm.
are trying to navigate it, and with every turn, there's that chance for the member to get lost, to disengage, to not understand what they need to do next, and to have the issues be more complex and more
Mhm.
confusing that they're just not followed through on. Um,
Yeah.
I think the
And you
good.
said something very important
Oh,
there, Amy,
go ahead.
which is around our members feel lost. And so if I'm a health plan leader like the ones that are on the phone today, I'm probably experiencing that more so on a daily basis than ever before because that loss is creating that lack of engagement, right? And so it's how do we take a number of these disconnected or fragmented portions of our healthcare system that are required to create a unified journey for the mom and do so in a path that is easy to understand. It helps create trust, but then it also creates sustained engagement on the path to a full-term delivery, right?
Yeah. So, and I think there's good news, right? The good news is, um, it's not a resource problem at this point,
Mhm.
right? So
Yeah.
it's a connection problem. And when we can shift to a more connected model, I think we can reduce those handoffs. We can reduce that member confusion and reduce the drop off. I think we can have a more single path where it's a continuity. It's an experience that members can follow, and
Mhm.
care teams and the member can actually be able to manage.
Yeah. And so talk to us about, Amy, what that journey looks like.
Yeah. So if we take, for example, we anchor here with Maria.
Mhm.
She's a 35-year-old here, and she's managing diabetes and hypertension, navigating postpartum depression. And her
Mhm.
story sounds complex, but it's also incredibly common. So this is exactly the type of situation we're speaking about, where risk can compound really quickly if that care isn't connected. So
Mhm.
I like to frame it as it's not a set of programs or touch points, but a path that can adapt around Maria. So I think this really demonstrates that. And what this all starts with is identifying someone like Maria. She
Mhm.
clearly meets high maternal criteria. She can be identified early using claims. And
Yep.
then these include, clinical indicators, social risk data, as well as, different screenings and signals that really allow engagement for someone like Maria to
Mhm.
begin before things escalate or those risks become a crisis, not after, right?
Yep.
So if Maria is enrolled, then we have the situation where onboarding into a certain program or path really matters. And if it feels heavy or transactional, I think Dr. Jones alluded to that, we run the risk of losing someone like Maria pretty early on.
Yeah.
So it's important that we simplify this experience for our members. It should be intuitive and feel relevant to her. So by being able to receive, multilingual, a lot of our expectant moms, mobile first kits are really the way to go. Um, there's also that live human support, but no setup, no barriers, so simple onboarding and it's immediate, that frictionless interaction. So from day one, Maria is completing validated screenings, and that includes things like PHQ-2, PHQ-9,
Mhm.
directly in a platform. And from that point, you're able to um, have this moment where we can come into a place where we're building a rhythm with Maria, not adding burden. And so she's engaging in a way that fits her day to day, sharing key inputs and staying connected. It also gives the provider or care team members a very clear picture of what's actually changing for her, both physically and emotionally. Um, and this could be, brief check-ins.
Yep.
That could also include her vital signs, and things about engagement or her mood. And then
Mhm.
that data can be collected and reported in real time. And that's what enables earlier interventions. If we talk about someone like Maria, we also have the ability where she can receive education. So that would be tailored to her diabetes, her hypertension, her mental health.
Yep.
And she's in her journey, right, with all of these things, but the support is relevant, it's timely, and it also makes it actionable for someone who's dealing with so many complexities. So then we can start to trend, right? And we can start to see things, and we're not reacting late. We're stepping in while there's still time to change Maria's trajectory. If there's things outside of a normal range, whether that's an assessment or a blood pressure, to put it even that simply, it can be escalated in minutes rather than days or waiting for the next appointment or no appointment that results in an ER visit. But, um, between the early intervention
Yeah.
and avoidable ER visits and admissions, it's important to um, mention also that this support doesn't taper off after delivery, right? So that postpartum is not a step down in risk for someone like Maria. It's often the opposite. So care
Mhm.
stays in a phase where we can adapt with whatever she needs as she recovers and starts to manage her conditions without being pregnant and navigate not only all of those things, but including her mental health. So um,
Yeah.
it's all connected on the back end, I would say, staying engaged and all of this meets, NCQA and CMS and, care requirements. So that continuity is what helps to drive that, um, everything throughout the pregnancy, but including the postpartum care completion rate that we mentioned early on.
So that engagement and that continuous engagement that we want from our members, we know, and everybody on the phone will likely agree that it's a very difficult thing to achieve. And I think the approach today, it seems like it is it's very ad hoc, or we try to make it continuous, but the mechanisms are just not there. And much of what you were talking about, Amy, everything from the multimodal communication to the providing tailored education and even postpartum support. we can't just do this, let's say, by making this an ad hoc process, right? It has to be something that's a lot more real time. And we all have smartphones, right? We all have smartphones that have, in this day and age, have made our process and made communication synchronous and live. And so, can you talk about how that technology, if not something that health plans have done before, is something that should be that should be adopted, and why it's helpful and effective?
Yeah, so I think one of the things that we haven't mentioned enough is provider collaboration. And I think one of the main things is, that's supported through her journey here.
Hmm.
So, we're sharing stratified actual insights, not only with Maria, but with her obstetrician, with her
Yep.
PCP, with specialists, behavioral health providers, as well as the health plan care management team. So not only is this something that, in real time can intervene, but it's something that provides the ability to close gaps,
Hmm.
align care, and support quality. And I think that visibility is something that if it hasn't been used for, before, this is something that can create the connectivity pretty seamlessly without creating more fragmentation. So Maria isn't left trying to piece everything together herself. Her providers aren't trying to figure out what's happening everywhere else or relying
Hmm.
solely on Maria, who's trying to learn how to navigate. It really is something that I'd say it is a puzzle that's been put together. So for, all intensive purposes, it really gives the path for Maria to walk on based on her cues and her activity. So I think that's something that's very unique. And, I think from your perspective, Dr. Jones, from explaining this kind of journey, is this something that you're seeing as a clinician, or is this something that you're, um, feeling would make a difference for patients that you see, in your clinic and who are in a similar situation to Maria? That would be something I'd kick to you.
Yeah. So we're not seeing it. We're seeing quite the opposite. We see Maria's trying to figure out their lives themselves instead of having this beautiful, tailored approach where you have, early risk assessment, continuous risk assessment. The beauty, I think, is in between visits, having a window of what's happening to the patient in between visits. I mean, because that's the big part of where patients run into trouble. It's in between visits and having that real-time availability of what's happening in between the times that she's seeing me. Is she actually checking her blood sugar, seeing the subspecialist that we've sent her to? Uh, how is her mood? Is she depressed because of all that's going around with her? We don't get a window into that, and I think having a journey like this of personalized whole person care would really impact the patient's outcome.
Yeah.
And having that live communication with her provider is
Right.
essential and not waiting for that next visit.
Right. No, I think that's very, very telling. And so one of the things that we want, we're seeing a lot of themes here kind of converge, is that a continuous engagement model is only successful via the vehicle, the highway that is made available to our moms. And if we're able to provide a highway that's continuous, where they have access to all of the key resources and can take, exits off the on-ramp, as you will, they can deliver superior outcomes from the perspective of fuller term birth, less NICU stays, meeting the provider when they need to, post delivery, et cetera. And so I believe what we have on the next slide is kind of what that interaction looks like through a smartphone based intervention, right? And this is from the eyes and the perspective of a Medicaid mom's interaction. Because for those who are on the phone, that is what's most important here. And in
Mhm.
fact, all the work that's being done is focused on uh, moms who are delivering through the system via Medicaid. And these are some of the hardest and the most challenging moms, and they're the ones who need it the most. So I want to highlight, what this does from a from an outcomes perspective. Uh, what we really see is when we provide members and especially moms who are with a baby feeling overwhelmed and isolated into a virtual care experience, such as the interaction we just saw, you see calm, you see assurance. And then from the health plan's perspective, there are key KPIs that we ultimately see improvements on. And so typically, when programs might tackle one or two of those issues that we were just talking about, one at a time, we're really focused on how do we enable the moms to close the loop, right? Because when you close the loop, that's when you create um, empowering outcomes like the ones that you're seeing. And so, Dr. Jones, from your perspective,
Mhm.
walk us through some of the most important metrics from your perspective as it
Mhm.
relates to how, effective virtual health can be a strong aid and predictor of better delivery.
Well, both of those examples that the one that Amy went through and the demo are really powerful examples of the importance of uh, getting a window, I keep using that term, into the lives of our patients when they're not in front of us.
Right.
The last young lady, very, very common, problems that, she was overwhelmed. She didn't have enough medication. She, hadn't seen a psychiatrist help or her health care provider postpartum. And,
Hmm.
that ability to connect with the Vita nurse virtually, uh,
Hmm.
probably saved her, uh, her saved her. Um, all of this is very nice, but like you said, metrics matter, right? So, what are the important metrics other than we're doing good work for this member? Some of the metrics that matter for me is the decrease in the cesarean section rate, 9.4, decrease in the preterm delivery rate, average gestation at delivery 38.3 in a high risk population. Excellent. NICU rates, which then translate into cost improvements and median stay into NICU. So these metrics, these real hard numbers, speak to the program and the program's success in helping members.
Yeah, and one of the things I want to do is I want to invite folks who are on the webinar that if you have questions, please ensure that you type them into the chat so that we can address them. We do have a question which is all the important, and I want to make sure that we're addressing it here now because it's very key, and it's around the data that is being shared and presented and if it's for a Medicaid pregnant population or is it for all lines of business? And the answer is that this is Medicaid. Medicaid is the most difficult and challenging population, whether it's from a chronic care perspective, behavioral health, and even in this case, what we're talking about, maternal health. But what we have seen is by removing all the fragmentation and creating a unified quote unquote package for our moms, you have the ability to create a pregnancy that is full term, Dr. Jones, as you outlined. One that the births are primarily vaginal versus primary C-section. And then third is that our moms' children are spending fewer days in the NICU, which all together improve the cost of the members. So that in turn leads to reductions in professional and facility claims costs, which is what we all want. And so, Amy, I would like your perspective as well, because from an operational side of things, it's not just one thing that is driving these outcomes, right? It's a combination, isn't it?
Yeah, so I think that's something really important. We look at, these outcomes and the numbers are sitting here and, if we're talking about a high risk Medicaid maternal population,
Mhm.
we're looking at one number, but it isn't. It's not a single intervention. It really is geared towards consistency across, Maria or Nicole or, anyone that you can think of their specific journey, and layering that with those quality improvement tactics, that early identification, continuous monitoring, and real-time interventions, and making sure that members are staying engaged through the immediate and extended, I want to point out extended postpartum period.
Mhm.
Right.
When we're talking about someone with chronic conditions prior to or potential gestational, conditions that may linger postpartum, there's a
Mhm.
Yes.
lot of complexity there. And so I think the idea is it's not a one size fits all. The system is hard to navigate even for the most experienced and educated person. So
Right.
making this really a journey and something that, and I've said this I think at least twice, we remove the barriers, we remove the difficulties in navigating and break that down. And rather than, and I think if you heard in my conversation with one of the patients, Nicole, it's not just telling someone what to do and hanging up. Coming to a visit and putting it on your 10-piece, discharge instruction, where the three sentences Nicole needs to follow are somewhere on page 6, that
Right.
she can't find. It is giving those instructions, holding hands if needed, and if nothing else, following up to make sure that that need was met,
Mhm.
Yeah.
because otherwise Nicole's going to get frustrated. Nicole's going to call an office. They're not going to call back, and she's going
Right.
to say, "Well, I called them." And really it is that extra step that
Mhm.
simplifies the process, because there's no question. We make sure that the need was met, and then we can go on to the next need, because my need might be different. Dr. Jones, your need may be different
Yeah.
from yourself or any other provider, but we have to go based on Nicole's needs also. So, or Maria's needs, or whoever the patient is, because otherwise there's not going to be value there, if there's too many barriers or it's too difficult. So
Yeah.
it really does make a big difference.
It almost sounds like to
Amy,
me
you
what
said,
you're.
oh,
Go ahead,
sorry,
Dr.
Shameet.
Jones.
No, I was just saying, Amy just, she said something that was really, important, at least for me as a provider. That follow through, was it done? Did the patient get to where she was supposed to go or get what she needed? And I think
Yeah, I think that's
that's,
what's most
you know,
impactful
critical,
about this
impactful.
virtual care model, right? Is that it ensures we're closing the loop for the member, and the member is receiving the care that they actually need, right?
Mhm.
That's very, very important. And then what's more is that, programs such as this or a model such as this, it's meant to complement and serve as a digital extension to any care management um,
Mhm.
function within the health plan or MCO. I believe there was a question that was related to that. So I hope that helps answer, that question. And when you really look at these outcomes, the way that we're looking at these outcomes and measuring them is on an intervention control group basis. So we are looking at individuals who are moms in this case who have enrolled in our program
Yeah.
and doing a comparative analysis to those who may have declined and not. And what we consistently see is in the intervention group, we always see that delivery cost improvement improve. We always see the average gestation of delivery improve. And we also see the occurrence or prevalence of NICU stays going down in that intervention group, always. And it's not only on these core measures, but then if you look at the comparative measures as it relates to, let's say, clinical drivers, blood pressure stabilization or blood pressure
Hmm.
control. Dr. Jones and Amy are one of the core metrics that we often look at for high risk moms, particularly those that have preeclampsia. Could you speak to just what you see from that perspective for the group here?
Well, Amy, rapid and immediate blood pressure control, I think, is probably one of the most important and uh, important drivers of outcome. And then, of course, sustained blood pressures throughout the time that the member is engaged. That alone decreases inpatient admissions, ER visits, and costs. Amy, you want to add anything to
Yeah.
that?
I mean, I would simply point out that when we're looking at risk, with a chronic care or a maternal population, we are seeing statistically significant reductions when someone is able to use their devices and have that out
Mhm.
of range reading and get that call, and making sure that when the person is checking their readings, we're talking to them in real time and being able to really triage someone to understand, is this something where it was human error, someone used the equipment incorrectly,
Yeah.
did they start talking and have their legs crossed, that they weren't using proper technique when they're checking their readings, or is it someone who didn't take their medicine? So we have some, health literacy and educating on
Mhm.
medication adherence, but you also have to take into consideration that, this is a high risk group. And so there may be situations where the values are valid and they're concerning. There's associated symptoms and it needs to be escalated. So, we're looking at, two human lives with our maternal population. And so being able to do that in real time and connect with the provider, similar to our
Wonderful.
resource discussion, not suggesting someone make a call, calling with if need be, and following up to make
Mhm.
sure the call took place or the
Mhm.
person went to the hospital setting. Someone that high risk, it may be an instance where they do need to be seen in an urgent or emergency care setting. But when members are having these readings, they're normalizing faster with that immediate outreach and intervention. They're
Mhm.
having avoidable ER visits. And when they are going to
Mhm.
the ER, they're being admitted less. They're staying shorter time frames. And I would say that's a huge area to highlight, that with the risk comes the responsibility, and we may need to rule out terrible things that could be happening. And if that is the case, members do need to be seen in that higher level care, or higher acuity setting. But
Yeah.
it is a big deal, that timeliness.
hmm Yeah. And so, let's now zoom out, right? Uh, what we what we're essentially saying and we're seeing is a similar trend, whether we're looking at outcomes for moms in the state of Maryland all the way through moms in the state of California, is that effective virtual engagement can create outcomes that are, Amy, to your point, statistically significant, right? And so, the main point here is that outcomes are achievable by adopting a structure and a program that really is focused on customization versus one size fits all,
Hmm.
but then also it helps create individualization for for our members, and then ultimately the outcomes that our health plan leaders are looking for. And so, from your perspective, Dr. Jones,
Hmm.
are there maybe one or two key metrics that kind of stand out to you from this, that you as a practicing OBGYN, you say this this is what we want. This is what we
Hmm.
want in maternal health.
So looking at this slide that you put up, Shameet, and disadvantaged zip codes specifically, I, I, I'm going back to maternal engagement. I think that is key. You talked about trust, Shameet. Trust fosters engagement,
Mhm.
and you can see that with the Vita model, uh, you've got 80% adherence to the device, and also a high behavioral health engagement, which is
Mhm.
also very, very difficult to get patients involved in their own behavioral health and find people to connect them with, or even uh, diagnose that they have a behavioral health problem.
Right.
The screening sometimes isn't done properly, or
Sure.
the screening falls through, and after being screened to connect with a behavioral health provider, it's sometimes difficult. So this, I think, is really, very important. And of course, the clinical results. I'm a clinician, so I want, fewer cesarean sections. I want fewer preterm babies. I want fewer NICU babies. That's what, the MFMs, that's what we do. That's where our life is dedicated to improve the clinical outcomes of
Right.
our patient. But there's so much more to our patients other than their medical problem. And engagement helps, wellness, diet, food, exercise, all of these things, transportation to get to the doctor, finding providers, all of those things impact the clinical outcome. And what's interesting here is that on this slide, the rural community and the minority community engagement exceeded the urban in our cohort of patients.
Yep. No.
And again, I think because trust in health providers these days is lacking. And once you can gain trust and have people engaged in their health care, their outcomes naturally improve.
So would you say, Dr. Jones, from your perspective, the key here for achieving these results, whether they are clinically related, whether they're cost related, or
Mhm.
all of the above, sounds like it's around that trust.
I trust, yeah. Trust is very important. I mean, definitely early risk assessment, continuous risk assessment,
Mhm.
we do that fairly well. But for the member to be part of the whole of her healthcare, trust and engagement, I think, is key.
Yeah. And I think that trust is also what, as you can see, on your screen here, is what helps drive those measurable improvements in those quality outcomes. We are very understanding of the the HEDIS measures that each of you as leaders at the health plans are striving to help accelerate the closure of, because as many of you are part of withhold states, this is very, very important. And these virtual health engagement capabilities have been very effective in elevating plans into the 75th and the 90th percentile for these. So an acquisition of those withhold dollars is achievable. And last but not least, going back to what Dr. Jones was saying about trust, it really does create higher levels of member retention within the health plan as well. And so, as we hit the top of the hour, there was one or two questions that we did receive in addition that we wanted to address, and one was around the how long it takes to see impact outcomes, if you will, through a program such as this. And Amy, could you just highlight, on average, how early are health plans who are adopting a virtual health engagement structure such as this, seeing those outcomes as early as how
Yeah,
many months?
I was going to say, I don't know that I would measure it all in months. I would say from the beginning, there's an onboarding and repeat or follow-up assessments that take place. So I
Yeah.
think from the very beginning, we're able to gain valuable information
Mhm.
about someone's state of being, whether it's a access to care issue or adherence or health literacy issue. So I think
Mhm.
from the beginning, there's that opportunity with our maternity model, obviously having to, run through the pregnancy and postpartum, but from
Mhm.
a chronic condition and just overall health status, we
Yeah.
start. I know everyone's going to be shocked, but not everyone joins a program and wants to use devices every day. So we do see some need for, relatability and having
Right.
people local feet on the street to where our members are living is really valuable.
Yeah.
So they understand the cultural and economic and location challenges that someone might be facing. But I would say from probably month 2 to 3, we see more buy-in, if you'll call it that. And then I would say from month 4 to 6, we really start to see some awareness, someone participating as a member of their care team more often. And then wanting to build those sustainable health habits, we're really seeing, I would say, a key time frame of like the 10 to 15 months, and that includes maternity and chronic condition participants. But there's value along the way, in little divots and certainly areas that consider gaps in care and quality care and access.
Well, I know some of the states have been at least many planned partners what they have found very advantageous is how helpful this is from a state reporting perspective, right?
Yeah,
To acquire key metrics and present them to the state as this is a top priority for many of the state legislators who are, putting these various, RFPs into place or RFPs that have already been procured, right?
for sure. Definitely.
Okay. All right. Well, very good. And it looks like we have one more question. Dr. Jones, perhaps you and Amy could highlight and speak to this one. Just real quick around um, moms who are going through their pregnancy journey, but also seeing and experiencing domestic violence. What have we experienced and how have we helped our moms, navigate that?
Yeah, so I can start by saying we have a number
Yeah.
of not only assessment or repeat assessment screening questions, but during, for example, an outreach, or even if we're over video, being able to see interaction or engagement in someone's home
Mhm.
is certainly another opportunity. When these issues are highlighted, most states are, we are not able to report on behalf of a member because of legality and state restrictions. However, we can do the screening and we can make sure that we follow up and work with moms or patients to highlight areas of opportunity and areas of resources,
Yes,
not only for
resources.
reporting practices, but for safety.
Mhm.
Yeah, echo Amy, making sure that we connect our members with resources is
Okay.
very important.
Yeah, no, absolutely. All right. Well, I know we're a little bit past the top of the hour, but what we'd like to do is end with a closing polling question for the group, which is, based off of what you've learned today, how would you now assess your organization's ability to improve maternal outcomes for high risk and hard to reach populations? Okay. So Eric, I'm not seeing and it looks like we've gotten more folks into our moderately effective or very effective. So, oops, see the polling question. So it looks like it has moved up a little bit, which is great to hear. Um, with that, I think we'll conclude. We really do appreciate you taking the time um, uh, to jump onto the webinar, and we hope you have a a key takeaway or two. And if there's any questions that you have that we weren't able to answer, we most certainly would like to follow up with you all so that we can help ensure that it has been answered for you. So with that, Eric, I'll turn it back over to you.
Great. Thank you so much, Shameet. I would just like to thank Shameet, Dr. Jones, and Amy again for their time and expertise. Obviously, maternal infant health is a huge topic, as is member engagement. So we really appreciate them, showcasing the value that Vita Health is bringing to that aspect of the industry. Finally, I want to thank the audience members. Thank you for joining us this afternoon and your participation throughout the session. Like Shameet said, if you have questions or follow-up, feel free to reach out to the Vita Health team. You can also reach out to me. I'd be happy to connect you with them as well. With that, we'll go ahead and close out. Thank you for joining us, everybody.
Thank you.
Here.